Good evening, viewers. Today's topic of discussion is imaging in radiation oncology. And the radiation oncology imaging is something like a surgeon with a knife. Without knife, a surgeon cannot do anything, and without imaging, the radiation oncologist cannot do anything. For understanding of radiation oncology, we should know what area we required to treat. In oncology practice, we consider the area of interest is GTV, gross tumor volume, which is required to be irradiated and given a full dose. But GTV is defined as the macroscopic extent of a disease seen in the naked eye or by radiological imaging like ultrasound, CT, X-ray, PET scan, MRI, and then we define the GTV. But whatever we see with these investigation as well as by naked eye, we definitely showed that there are certain potential microscopic spread of a tumor around the GTV. So we envelop it with this CTV. A margin is taken around the GTV, so that now we collect the CTV, clinical tumor volume. But there are certain tumor, some physiological and technical variations do occur. Like for respiration, may lead to the movement of a lung cancer and laryngeal tumor, and a bladder and rectal filling may lead to the movement of prostate tumor and bladder tumor. So that we give margin to that also for that movement of a tumor, that is internal margin. And then day-to-day movement, alignment, beam alignment, and though it is a precisely duty of trained radio therapy technicians to align these, and also uh, safety margin is given, that is setup margin. So now if we combine all GTV, CTV, internal margin, setup margin, now we conclude the PTV, which is required to be irradiated. So also we conclude the area nearby the organ at risk, so in order to give a radiation to that. So radiological and medical images of various types are employed at virtually every step of radiation treatment process, including the diagnosis, extent of a disease, treatment planning, treatment delivery, follow-up, and outcome evaluation. These images classified in several ways, and it may be broadly classified as a cross-sectional image and a projectional images. So I'll tell you about what is cross-sectional and what is projectional images. The cross-sectional images include the CT scan sections, MRI, PET scan, and a single photon emission computed tomography SPECT. But the latter are like projectional images are simulation images, board film images, CT scout views images are considered as a projectional images. In some cases, useful projectional images, for example, digitally reconstructed image, can be reconstructed from the cross-sectional data. I'll show you here how we construct this thing. You see, there's a multiple CT scan images in which the tumor is there. We draw contouring after the CT simulation, and then a volume of data is collected, and now we on a computer create a digitally reconstructed image, that is a projectional image. Now we know the area to be irradiated. So radiation oncology imaging solution fall in two categories: those that provide the more precise treatment planning image, and a system that facilitate increasing accurate dose delivery. In fact, most significant recent advances in radiation oncology have resulted from the development of application of imaging modalities like a CT scan and MRI. With information from the new imaging modality, it is now possible to define the treatment volume and a critical structures with a greater precision, reducing the marginal miss and irradiation of a normal tissue. So, there is a tumor morphology. The tumor morphology is essential because we intend to give high dose to the tumor and minimum dose to the surrounding normal tissue or critical tissue. Various imaging modalities like ultrasound, CT, MRI, PET are available to understand the better tumor morphology and so that we can give maximum radiation to tumor bed and a minimum radiation to the normal tissue. The MRI is somewhat superior to the CT scan, particularly in brain tumors like glioma, functional MRI, diffuser tumor imaging, MRI spectroscopy, functional MRI, tactography required to delineate the exact anatomical structure involved by the tumor. Furthermore, the brain tumor edema is uh, better seen in the MRI images, as well as the brain stem structures is not very clearly shown in the CT image, but you can see the sagittal view of MRI, a very clear-cut picture of image of a tumor by MRI. So many aspects of medical imaging has been benefited by the substantial and sustained development in a computer technology, both in hardware as well as in software. The computed tomography image has already gained widespread utilization in various areas of radiation oncology. What are these? First, delineation of target volume, that is our tumor to be delineated. The determination of relative geometry of critical structure, optimal placement of a beam and a shaping of apertures, calculation of a dose and its distribution, as well as follow-up evaluation and a treatment outcome. So CT imaging has fully utilized in the radiotherapy planning, and you see in the case of fusion techniques, the CT is base. You must have heard about the CT MRI fusion, PET CT fusion, but you never heard of MRI's PET fusion. Why it is so? Because the CT is the base. It gives you an accurate electron density for a dose calculation purpose, so that we combine with this, so the CT is always there with in the fusion images. One is CT images, other may be a different thing. PET may be, MRI may be like this. So MRI images present unique anatomical information of a tumor detail, though the digital value cannot be directly used for a dose calculation that I have already clarified. The MRI image detail with a correlated with CT attenuation value can provide a powerful planning tool as it gives 3D imaging and a better tissue contrast. MRI has been effectively utilized for the treatment planning of a brain, pelvic and prostate disease. As the development of high-speed scanner taking place, utility of MRI planning of a head and neck, thorax and abdomen is evolving and very rapidly evolving. The spectroscopy, functional MRI, PET CT image fusion can give a detailed information about the biochemical changes, hypoxic status of a tumor, relative cellular progression, regression, so that we can understand the biological target volume in a much better way. In 53% cases, MRI altered the CT planning in brain tumor. But MRI has its own limitation. First of all is a slow speed. Second is the motion artifacts and inadequate software for RT planning. The images may be distorted by variation in a local magnetic field caused by the presence of metal object in the environment or within the patients. Like a patient with the metal implant will have problems in MRI imaging In addition, the bone does not give explicitly appear in the MRI images. So, so far as the PET scan is concerned, the positron emission tomography image do not provide the resolution as CT or MRI image, but it do provide the physiological information, biochemical information that may be important for localizing the certain disease and determining the response of a radiotherapy by their hot spot and a cold spot. PET CT fusion images are very helpful in treatment planning and follow-up. The ultrasound is a good limiting tool for abdomen, good imaging tool for abdomen, ultrasonography, prostate and detection of lymph node metastasis and head and neck cancer. It helps in the guidance of various implants like perineal implant in prostate and cervix. It is also important tool for assessing the response of a therapy. So many linear accelerator are coming nowadays with the inbuilt prostate system, ultrasonography system, so that you can delineate the tumor during the fraction and interfraction movement. Like you see the machine HD Versa is having a trans-abdominal probe as well as the transperineal probe, and then you can image the patient online during the implant, counter checking the implant in situ, as well as the mobilization of a tumor can be utilized here. So they comes under the non-radiation based imaging system. This system acquired the 3D image in order to help align the target to correct the intrafractional error, and it is mostly used in the prostate, lung tumors and a prostate. The simulation in conventional method 24 to 47% cases show inadequate tumor coverage by conventional simulation, and it was observed that 55% need a CT information, and this will help to increase the overall survival 6 to 10%. Why? Because if you are sure of a good tumor volume coverage, then you can enhance the area of full dose, giving a 20% more extra dose to the tumor, so thereby avoiding by increasing the overall survival by 6 to 10%. This can be achieved by only if a radiation oncologist get a proper information by radiology about the tumor morphology. The modern CT simulation have advantage over conventional CT simulation machine or X-ray machine, in which the tumor localization and verification is better, and digital data can directly transform to the planning system. A linear array of detectors is mounted on the gantry arm, and digital information of radiation exiting from the patient is acquired by rotating the simulator gantry, the X-ray tube. The advantage of such CT simulator or conventional unit is that the elimination of spatial restriction on the CT gantry. Patient is more likely to be imaged in exact treatment position, including the use of patient support device. These CT simulators only different from the conventional CT simulator, that the CT simulator having a wide bore aperture around 80 to 85 centimeter, like a conventional CT simulation having a 70 centimeter diameter, so that the larger bore diameter is give adequate inclusion of immobilizing devices. Along with that, the patient can be imaged. The major disadvantage in this time needed to image a large number of CT planes and the poor image quality in the conventional CT images. In tomotherapy, the CT is mounted with a therapy system. The CT is mounted on the linear accelerator, so the online treatment planning can be rectified as and when needed. So, little bit about the electronic portal imaging devices. The EPID in the radiation oncology is a recent development, may have a profound impact on the overall accuracy of radiation treatment delivery. With these devices, daily imaging of a treatment, localization and verification become possible as well as feasible. Along with acquisition, image acquisition, analysis, storage, and distribution of portal image can be performed very easily. And in a modern linear accelerator, the APID is inbuilt system. Besides its use as a replacement of a port film, APID can be applied to the other area of radiation oncology. These include monitoring of a patient and organ motion during the treatment, use of exit dosimetry treatment plan verification, recording of a dynamic multileaf collimator movement for intensity modulated beams for IMRT treatment, as well as accelerator quality assurance procedure. You see here the modern linear accelerator, the APID on this, so that you give a radiation and then by this dose for the dose which is exit can be imaged here, and then you can see the tumor during the treatment and in between the treatment, the mobilization, because the APID image is stored. In future, image acquisition, communication, storage procedure for acquiring the different images, CT, MRI, PET simulation, for planning and verification will be a part of integrated system in the field of radiotherapy. The treatment planning and response assessment image can be used for planning and treatment and response, keeping in mind the importance of proper operational utility of imaging modality, as the assessment of response and the treatment planning execution may be affected by improper knowledge and about the imaging. Example, the assessment of response in reduction of tumor size should be done by measuring the tumor volume in the largest dimension in the contrast scan image. Assessment may occur if a patient is scanned while the patient is on a steroid, which gives a false information about the exact extent of response because the steroid reduces the edema and vascularity, so the tumor volume falsely appears to be less than what is the actual tumor. If patient is imaged in the different makes of machine by which the different modality of patient scanning done in non-identical position, that are there are high chance of false assessment. So now this can be minimized by using the CT, MRI, PET fusion image. Therefore, it is necessary for diagnostic radiology should have a basic knowledge of radiotherapy, importance of radiotherapy position. Problem of moving structure, especially in the thorax and abdomen, is one of the concern in the radiotherapy planning and treatment delivery. It has been observed that a 1 centimeter movement can lead to the 5% dose, plus minus dose to the tumor area, and then as a rough data is being collected, the movement depend upon how much the tumor shape and a morphology change by day to day, like interfractional, or during the radiation, the intrafractional. So it is very important to deal the problem of tumor movement. This problem is now being taken by the tumor adaptive radiotherapy, image guided radiotherapy. You see here the Callisto system, electromagnetic tracking device, that is Callisto system. This system makes use of electromagnetic transponders, that is called beacons, embedded within the tumor, and motion of these beacons may be tracked in real time using the detector system. Beacons need to be placed by minimal invasive procedure, but their presence produces artifacts in MR images. At present, this system is limited into the up to the prostate tumor. So IGRT and tomotherapy is the latest advancement. IGRT and tomotherapy in the field of radiation oncology imaging has come of age. Now the imaging modality like CT, 4D CT, PET CT now integrated with treatment planning and delivery system, enabling radiation oncologists to plan delivery razor sharp treatment, especially for lung and abdominal cancers, are benefited by the ultra precise respiratory gating and image guided adaptive radiotherapy. So for that image guided radiotherapy or SBRT, you required fiducial markers, and these markers are implanted with these needles into the tumor area or around the tumor, so that you can image this thing during interfraction movement or intrafractional movements of a tumor, and allow the margin according to that. So at the end, the conclusion, the radiation oncology should have a knowledge of various imaging modalities and their application in field of radiotherapy. This should be an integral part of postgraduate graduate training program. There is a need of future research for improvement in accurate diagnosis and better understanding of tumor biology, and a problem of hypoxia and radio resistance need to be sorted out. The targeted treatment delivery is a key issue in the future, which can be solved by the help of various imaging modalities. Improvement is in image fusion, the portal imaging related to organ movement during the treatment evaluation response is being tackled in the better way nowadays. The organ movements and a dose delivery to the biologically sensitive, biological resistant tumor, it will be another area of research. In future, time adaptive radiotherapy and biological adaptive radiotherapy will be the major area of research. Thank you very much. God bless you all. Let us tell you about the regarding the CT MRI fusion, how we do it. For regarding the CT MRI fusion technique, you first put the CT scan along with the marker, and the CT simulation is done, and then you acquire the images of CT. And the same position, a different marker, now you different shape marker is put on the MR during the MRI simulation, and then you acquire the image. Now both the CT and MRI images scan by scan whether having a tumor should be overlapped, and then the CT MRI fusion image is created. That is I wanted to just tell you.